Business Development here at Center for Change. I'm here with Quinn Nystrom, our presenter today, and I'll introduce Quinn in just a minute. We're so happy you all could be here, and we need to do some quick housekeeping items before we get started. I want to go through it as quick as I can so that we have plenty of time for Quinn's presentation. So you'll see on your screen some vital information that you all need. So a copy of the PowerPoint can be accessed via the link in the chat. Oops, nope, I've put it in the chat. Let me say that again. A copy of the PowerPoint is in the chat. Keep in mind that the chat is one way. We have so many attendees, which we're so grateful for and thrilled about, but it makes things complicated when it comes to chat. So we have the chat one way, so we can send things to you, but you can't send things back to us. You certainly can in the Q&A section, and we'll talk about that in just a minute, but in the chat, we'll send information to you there. So you'll see a copy of the PowerPoint in the chat. If you'd like to download that, you're more than welcome. In that same chat is a copy of the post test. This is for reference only. You have to take the test online in order to receive continuing education credit. But you're welcome to take a look at the post test, print it out, whatever you'd like to reference during Quinn's presentation so you can take the test after. You're welcome to submit questions in the Q&A tab. We'll keep an eye on those. We won't interrupt Quinn during her presentation, but we'll save time at the end for us to be able to try and address some of those questions. So please feel free to put questions in the questions tab and the Q&A tab. I'll keep an eye on them, and then we'll get to some at the end. When the webinar ends, in the window that you see right this minute, where you see my face and Quinn's face, you'll see a pop-up that will be the webinar evaluation. If you'd be so kind as to take just a minute to fill out that evaluation, that's really helpful information. It's completely anonymous, so feel free to be candid in your feedback. We tabulate those results, and it's required of us to send those results back to the CE providing approval entities. So if you'll fill that out, that'd be great. It'll take you a minute and a half, maybe. And then also when the webinar ends, and what I mean by the webinar ends, either I end it because we're finished, or you have to leave, if you have a client at the top of the hour and we're still going for a minute, when you leave, you'll see a new browser tab will pop up with a link to take the online test, to take the post test. You must take the post test online in order to receive continuing education credit. Once you receive, once you pass the test, that CE certificate will be available for download on the test site. There's a button there that you'll see that says download certificate. So look for that button after you take the test. All right, I'm gonna stop sharing my screen and want to introduce my friend Quinn Nystrom. I'm thrilled to have Quinn here with us. We've worked together and have been friends for a number of years, and get to travel together from time to time, and I thoroughly enjoy her as a human and a person, and she's kind and lovely. She's an amazing advocate for people who have diabetes. She's an advocate for affordable insulin and affordable supplies for patients and people who have diabetes. She sees the vulnerability and the kind heart in everybody and is looking for ways that she can serve. And we're thrilled to have a relationship with Quinn and have her be our presenter today. So with that being said, I'm going to turn it over to you, Quinn, but I'm going to have you share your screen first before I turn off my mic and my camera. So I'll let you do that.
Okay, we'll do that. Let me share. We practice this, so we'll see how quick I can do it.
You're good. We got nothing but time.
Okay.
There it is. Okay, I'm going to turn off my mic and my camera, but you know the drill. If you need me, just holler. I'll pop back on. Otherwise, I'll come back at the end of the presentation and we'll take some questions at that point. So I'll turn it over to you, Quinn.
Sounds great, Tamara. And while you were doing the introduction, I saw a couple of hands that got raised and also a question. So I'll have Tamara and Shelley kind of follow up while I'm presenting. I know it's a little different when it's virtual, and anyway, so appreciate the kindness and grace that everybody extends, especially in a post-COVID world. So thank you so much to Tamara and to Center for Change for inviting me back. We've been together now working collaboratively since 2016, and it's honestly just been an honor and a privilege to be able to get to do this work with them. I'm really passionate about the topic of diabetes, and this is kind of a new presentation that Tamara and I sort of brainstormed about. So we'll love to hear any feedback, also any questions. I always try to keep time at the end, so you can really ask me to further explain something, go over something. If you just have a random question that you thought about in relation to diabetes or eating disorders, feel free to have that as well. So today's presentation is kind of the current state of diabetes. So what mental health and dietary professionals really need to know about the latest treatments, research, and co-occurring illnesses. I think in the US, we hear a lot about diabetes, but then we also get some misinformation or just things that have carried over years or decades about what people think about diabetes, either how it's caused, how it's prevented, how it's cured. Uh, just as a side note, there is no cure for type 1 or type 2 diabetes. So I'm hoping to kind of delve into that in this presentation so that we can get a really good, at least kind of overview here in the next hour. So, okay. So the presentation, we're going to start by kind of going over diabetes in America. What does that look like? The different types of diabetes. Then we'll kind of talk about current treatment options. So again, what is the history of treating diabetes as a chronic illness? And I'm going to say this is a big part. I should have made it a larger font size. But what are the barriers? So we know that insulin was discovered over 100 years ago, but why in 2024, now almost 2025, do we still have quite a lot of people in the United States who struggle with the daily management? They struggle with financial barriers, right? There's several kind of things that play a part into, you know, I I think sometimes we want to think of things in a black and white realm of okay, so Quinn has type 1 diabetes, and this is her one number that we'll associate with how well she's doing with managing the disease. And yes, you can get that number. That could be your hemoglobin A1C, which is a blood test they draw, or for people who are on a continuous glucose monitor, they could look at your time in range as a different component. But again, I think there's a lot going on beyond one number. And so that's really what this presentation is looking at, is how can we look at the multiple things that impact somebody's life with diabetes, and how as healthcare professionals, how can you best be attuned to that, know some of the different things that could be going on, and then how do we best address that? And then the last part will kind of be some research, right, about future treatments, about co-occurring illnesses. Now we know so much more than we did when I was diagnosed in 1999. We'll talk a little bit about a cure, and then again, we'll talk about some of those strategies that you can bring into your everyday practice with patients. So, about me, you may know me from some other presentations, but I've lived with type 1 diabetes since March 17th, 1999. So I've lived with it for 25 years. My younger brother was diagnosed 2.5 years before me when he was 5. I was 13. He was diagnosed in 1996. I'm one of 3 siblings. The older sibling did not get diabetes, so it was just the 2 of us, the younger siblings, who got it. Um, and I'm born and raised in Minnesota, still live here today. Have a family. I have 2 stepdaughters, a husband, and then this picture was taken actually about a year ago when I was pregnant for the very first time. And so I'm starting with this picture because I think it perfectly kind of encapsulates what I'm going to talk about, which is, a lot of research, can be a lot of numbers. But to me, a story can really help us tell and inform people of what diabetes in America looks like. And so obviously you see this picture of me, I'm cradling my baby bump, everybody's so happy for me. But 25 years ago, when I was diagnosed with type 1 diabetes, I was told a lot of things that we would say is no longer true today. And frankly, I don't even know if they were true 25 years ago. But I remember being a teenager and going to different diabetes conferences, seeing different medical professionals, and being specifically told I would not be able to have a baby of my own. And even if I was to get pregnant, how dangerous that would be to my health and also to the babies. It was kind of Steel Magnolias kind of esque. If you've seen that movie, I did once, bawled my eyes out, and have never seen it again. Um, but this is, you know, what I was told 25 years ago. Now, obviously, I got pregnant, and I'll tell a little bit of that story as we weave through the presentation. Um, because I think not everything is just kind of how we see it. So that's what we're going to delve into today. So, all right, diabetes advancements. I love this picture on the left. This is a picture of one of the very first insulin pumps that was ever discovered. This was the first kind of wearable one. You can see it's like a massive computer backpack. Probably not very accessible. Probably not all the school kids wanting to like run around in a gym and school with like a massive computer on their back. Um, now I'm trying to think of where's my insulin pump. Let me um so you go from that, which I think is so interesting. And the first one was in a hospital, and I think it was the size of a refrigerator. So the backpack was actually a couple iterations. But just to kind of show you the difference now, this black and white patch kind of, that's my insulin pump now. And it's fully controlled. You'll see actually I have an Omnipod thing on there, but it's fully controlled by my iPhone. So again, huge advancements made. Now, insulin was discovered over 100 years ago by Dr. Banting up in Canada. That really, prior to insulin being discovered, diabetes was a death sentence. They did something called the starvation diet. They would say, eat as little as possible, and they kind of hoped you would make it a year. But usually people wouldn't make it past that time, even on the starvation diet. And so when insulin was discovered, it was a massive breakthrough because it meant that diabetes was not an automatic death sentence. And so, there's been a lot of discoveries since. We saw in the 70s, kind of, again, the first kind of commercial insulin pump. Um, and again, there was a lot of kind of different iterations. Oh, I'm sorry about that. Um, there also was different iterations of insulin. So yes, it was discovered back in 1921, but we've had advancements in the type of insulin. So again, was it human insulin? Was it pork insulin? Was it um, uh, fast acting? Was it long acting? And then in the 1980s was the first time you could actually check your own blood sugar at home. So I had a great uncle with type 1 diabetes, and he talks about, when he was a kid, he would have to pee on a stick to try to figure out what his blood sugar was. Or, so again, lots of advancements. In the 1990s, we saw short acting insulin get really, really better. And then we also saw the first continuous glucose monitor, which again, for people who may not be familiar, it is similar to an insulin pump in the sense that a needle goes in you, a little cannula stays, and then it tests your blood sugar for you and gives you a reading every 5 minutes. And I get that reading on my watch. I don't know how good I'm going to do, but so my blood sugar is 122 right now. And I also get that on my phone. So, but when it first came out, certainly not that small, not that accurate. The needles were quite painful. The readings just weren't as accurate as you'd want. So again, lots of improvements made, which has improved how we treat diabetes. If you've been to a presentation before, you know I'm going to go over this as quick as possible, but I think it's critical to go over, which is, again, I'll just speak about US numbers. Type 1 diabetes, which is what my younger brother and I have, and what my great uncle had before he passed, that makes up about 5 to 10% of the 30 million Americans who are diagnosed with diabetes. So it's a smaller percentage. We used to call it juvenile diabetes because we thought that it was just young people, kind of under the age of 18, got diagnosed with type 1. So they would call type 1 juvenile diabetes, and they would call type 2 adult onset diabetes, if you kind of remember those names. Because again, they thought type 2 diabetes, only older adults get it. Now those two names have been taken away. I think they were taken away, gosh, maybe eliminated 10 years ago, 15 years ago. I'm trying to remember, because they weren't as accurate. Type 1 diabetes in layman terms is my pancreas shut down. It's an autoimmune disease. Unfortunately, we don't know more about why does my cells attack the other cells to shut down my pancreas from producing insulin. They haven't been able to pinpoint that. But that's what happens with somebody with type 1 diabetes. So that's why somebody with type 1 has to know what their blood sugar is every day, all day. That's why a lot of us who can go on a continuous glucose monitor, that was an amazing advancement because we no longer had to prick our finger 12 times a day. Also with type 1 diabetes, because your pancreas shut down, it broke down, you have to give yourself insulin. So you can do that either by manual insulin injections, or like I said in the previous slide, you can use an insulin pump. I've been on an insulin pump since I was 16. I've used all different kinds. My younger brother, who's had diabetes 28, 29 years, he literally just last week went on his very first insulin pump. So what I would say is, even though research shows you can kind of have better management with an insulin pump, for some people, they just like shots. Like, they don't like to have an external device on them. And so I always say whatever works for people works for people. It took my brother a little bit, and now he's like, why did it take me so long, Quinn? But so type 1 diabetes, you absolutely have to have insulin. There's not somebody with type 1 who doesn't take insulin, because every single one of us, even the 500, 600, 700 plus that are on this webinar, you all need insulin, but your pancreas produces it for you, which is very nice. Now, we have to become the pancreas in our mind, and that's where the disease gets very complicated to treat, because I'm not a medical doctor. Frankly, I hate math. I didn't like science, and I hated needles. So the great irony of me getting type 1 diabetes is something I'll chuckle with God one day. Type 2 diabetes makes up roughly around 90-95% of people in the US that have diabetes. It's what we hear about probably the most often, but I also would say it probably has the most misconceptions out there. Type 2 diabetes, your pancreas still produces insulin, but you have an insulin resistance issue. So what we often hear about is that people have caused type 2 diabetes because they're overweight, they have an unhealthy diet, they are not physically active. And though that can be true for some people diagnosed with type 2 diabetes, it's also true that you have older people in nursing homes in their 90s who are quite small, quite petite. They still get type 2 diabetes because it's about insulin absorption. And as our bodies get older, they don't function as well. So again, for some of those people, it has nothing to do with weight or physical activity. So there's different ethnic groups that are at a higher propensity. If people are of a certain age, a certain gender, right? So there's several factors there. And then lastly, I mentioned gestational diabetes. That is a very small kind of percentage. And what gestational diabetes means is that you get diagnosed with type 2 diabetes while you're pregnant, but they call it gestational diabetes. I've had some friends, and again, it can vary on the severity, but they are required to then test their blood sugar. Um, and the pregnancy has caused an insulin resistance issue. So oftentimes that's you're growing a human. And so everybody's body reacts different. And so some people they will their medical team, their OB team will put them on kind of a more structured eating plan or look at physical activity to see if they can help that with the absorption. But then sometimes some people with gestational diabetes will take insulin to assist. I had a girlfriend of mine who did that. So it just depends. With type 2 diabetes and gestational diabetes, just because somebody takes insulin, or let's say they're on an insulin pump, and I've heard this so much, and that's why I bring it up, people will say, well, now I have type 1 diabetes. You can't change to a different disease, right? Because it's what's at the core. Does the pancreas work or does it not work? And then again, with gestational, are you pregnant? Are you not? And then typically after they deliver the baby, um, the gestational diabetes goes away. But people who have gestational are at a much higher increased risk for developing type 2 diabetes later on in their life. So, um, there's all different ways that people get diagnosed. I was diagnosed because my mom noticed I was drinking a ton of water. I was going to the restroom all the time. She kind of noticed those signs and symptoms of a high blood sugar and she recognized that. Um, some people get really, really sick. Some people, have it caught early on, which obviously is always the hope. Um, and then gestational diabetes, I think it's more common practice now. They had even asked me actually when I was pregnant, like, was I going to take, what do they call it? Like the diabetes juice test or something, like to see if I had gestational diabetes. And I was like, look, I already have type 1 diabetes. My pancreas crapped out years ago. I don't need to do the juice thing. I already know I'm locked in, right? So, and then for all of these, like I said earlier, there is no cure for diabetes. So, what I'll hear with type 2 diabetes is people will say, well, if I was on insulin and let's say I lost X amount of weight or started a physical activity program, now I don't have to take insulin, or maybe they reduce how many oral medications they're taking. They'll say, well, I cured myself. Or you used to see it on that horrible show, The Biggest Loser. Like the doctor would be like, you cured yourself of diabetes. And I would just be like, oh, it was so cringeworthy for me. Because though you were able to get off medications, that doesn't mean the disease is totally erased, right? It can come back at different times. And so when we talk about a cure, it's something we hope and wish for, obviously, but we're not there, unfortunately. We're severely underfunded on the federal government level. Um, okay, so let's talk just kind of a brief overview here of the prevalence. So over 30 million people in America have diabetes. Um, the diagnosed number is that 29.7 million. That's why you'll hear me say diagnosed. Uh, there's about 8.7 million that are undiagnosed. So what they're really looking at there is people with pre-diabetes, who maybe just have not been diagnosed yet, but we know they're already at that very high risk, kind of on the borderline level. We also know that, I'm just going to move my thing so I can see my slides. We know that over 300,000 children and adolescents under the age of 20 um, are diagnosed with diabetes. Now, about 300,000 is with type 1 diabetes. So again, when I talked about how we used to call it juvenile diabetes, for the most part, people with type 1 diabetes that you meet or maybe you see in your practice, typically they were diagnosed under the age of 18. I would say the large majority. But I know a woman who was diagnosed at 38 years old with type 1 diabetes. And sometimes they get the wrong diagnosis initially. They'll be told they have type 2 diabetes because the medical professional will say, well, they're 38 years old, they're having blood glucose issues, right, that are elevated. So they kind of slap a type 2 diagnosis on. But then they later find out, no, in fact, they have type 1 diabetes. So that's why I think it's important that kind of we all know, so that we can better detect it, get better information, and get better treatment for people who may be diagnosed young or old. And we also know, with the rising rates of childhood obesity in America, we saw the number of children under the age of 18 increase with type 2 diabetes. So we did see a little bit of that correlation. And so, again, if there was a young kid going in, sometimes they were getting diagnosed with type 1 when in fact they had type 2. And it's important to know because it's a different treatment. It's kind of different things that you're looking at. And again, it's the same disease in the sense that it's about your blood glucose levels, right? But it's different in the cause. So we know just under 2 million adults, 20 or older, are diagnosed with diabetes. Again, report having type 1 diabetes and using insulin. So for people who think, oh, it's just like a little kid disease, well, those little kids grow up. And I would also say, because of the amazing advancements in diabetes technology, we're living a lot longer. And so you're seeing people who are getting like the 50-year award of 50 years lived with type 1 diabetes. Where in the past, you didn't see that as much because we didn't have the advancements. And so your life expectancy was much lower because of a diabetes diagnosis. So when we look at, okay, adults age 18 and older on kind of the most recent statistics we have from the CDC. I talked earlier about with type 2 diabetes, there's, I think 9, 10, 11 risk factors in getting type 2 diabetes. It's not just your weight, your BMI, and your physical activity level. Okay. It's not just those three things. Those are on it, but not all of them. And so I think it's important to show, and I know this especially in the state of Minnesota, where we have a large American Indian population, but they are the hardest hit along with Alaska Native adults. Their prevalence is right under 14%. And then it's followed by non-Hispanic Black adults around 12%. I think in the state of Minnesota, I think our diabetes prevalence is like around 7%. And then when you look specifically at American Indians, it's almost double that. And so we know for whatever reason that they are harder hit with type 2 diabetes. We also know 13% of adults with less than a high school education had diagnosed diabetes versus about 9% with a high school education. And less than 7% of those with more than a high school education. Now, looking at income level, kind of socioeconomic levels here, adults with a family income above 500% of the federal poverty level had the lowest prevalence for both men and women with diabetes. We also know for both men and women, prevalence was higher among adults living in non-metropolitan areas compared to those in metropolitan areas. And I'll talk about that a little bit later. Why is that true? And hopefully I'll be able to help kind of put some of the puzzle pieces together and kind of the background of why we have these numbers. Okay, and when we're talking about children and adolescents under the age of 20, we've seen an increase in the incidence of type 1 diabetes. Now, what I think is interesting is most people, kind of on a surface level, will think that our diabetes rates have gone up because of type 2 diabetes. And you'll often hear them say, well, that's because of the obesity epidemic, which again, I'm not saying that's not a factor, but what we've actually seen is the numbers have increased the most with type 1 diabetes in adolescents. Now, we've seen again, non-Hispanic, Asian, Pacific Islander children and adolescents had the largest significance in the increase. We also see that non-Hispanic white children had the highest incidence. We've seen that type 2 certainly also has increased. And we've seen it increase in all racial and ethnic groups, including some of the ones that I mentioned on the previous slide. And non-Hispanic Black children and adolescents had the highest incidence of type 2 diabetes in kind of these most recent numbers we got. So I will talk about that. So we'll kind of put a pin in that as I kind of go over some of this. So now, diabetes is currently the most expensive chronic disease in the nation. It is incredibly expensive, not just personally for the person who has diabetes, but also for our government. So diabetes in 2022 cost our government over $400 billion. One of every 4 healthcare dollars spent in the US is put to somebody with diabetes. So we know how much money it is to simply keep somebody alive with diabetes. And what I'm saying is, I think it's really sad that we haven't made greater advancements, maybe in our healthcare system, where this seems to continue, where we are the #1 spot for the most expensive chronic disease, when I don't think we need to be the #1 spot. And so I do a lot of advocacy work in my volunteer time around insulin affordability. And you see it just directly on that. And I'll talk a little bit about that and why that's such an issue here in the US. But it's a very expensive disease. Now, 1.3 million Americans ration their insulin. Now, that's people who, again, the CDC was doing a national health survey. They said, yep, I ration my insulin. I've also seen other studies that say 1 in 4 people who are on daily insulin ration. I've seen reports as high as 50% of people with insulin ration because they can't afford it. And that to me is a tragedy in itself. Now, I know I gave you the number of 30 million Americans diagnosed with diabetes. About 7.5 million of the 30 million rely on insulin every single day to stay alive. Now, obviously, all the people with type 1 are in that category, but you also have some people with type 2 diabetes and gestational diabetes that are in that category of they have to rely on it as life support. And I will say the saddest thing to me is Dr. Banting sold the patent for $1 after he discovered insulin because he knew that this was going to save millions and millions of lives. And he wanted this breakthrough to go back to the people, right? And now what we see is, in America, that this vial of insulin, when it came out in the early 2000s, so right after I was diagnosed, you could get this vial for about $20, $25 retail price. Now the same exact vial, nothing has changed about it. They'll tell you there's some patent extensions, but that's kind of working the system. There's nothing that has changed about the insulin formulation in this vial. So I have the exact same product, but now today, depending on what pharmacy I walk into, we're not looking at $20, $25. We're looking at about $380 to $400 for one vial. And to put that in perspective, sure, people will say, well, nobody pays the retail list price of insulin. But I would say actually some people do, because if you don't have insurance, you're going to pay the retail price, right? And we also know in our country that we've made steps forward with the Affordable Care Act and covering people with pre-existing conditions, which I'm grateful for. It also caused for a lot of our insurance plans to be high deductible. And so, especially in those first couple months of the year, maybe even the first 6 months, if you have a deductible of $6,000, $10,000, there were insurance plans where for the first several months, I was paying the list price out of pocket until I hit that deductible. And what we know is a lot of people in our country do not have that type of disposable income. And it's stressful with the uncertainty, but it's also stressful because we don't know how we're going to pay to keep ourselves alive. Literally, me buying insulin is like us having oxygen to breathe every day. It is the exact same thing, but unfortunately, the price has been extorted in this country. And as a side note, if I go just north 4 hours over the Canadian border, I can get this identical vial of insulin for $20 today. And you don't need a prescription for it. In the US, you need a current prescription, and we pay an incredible amount of money. So I put this in here because people will say, well, I thought insulin was only $35 now. I thought, the president fixed it. Don't worry, I'm not going to go political. We made a big advancement in getting people over the age of 65 with diabetes to have a $35 a month insulin cap, but those are people who are on Medicare. So yes, it's a great step, and I'm thrilled for our seniors. We still have millions of people who are under the age of 65 who are desperately in need of insulin. And so I put this up here to say, you may hear talking points even from pharma saying, we have these patient assistance programs and nobody should be struggling to afford insulin. Well, then why do we have up to 50% of people who rely on it who are rationing it because they can't afford it? Because I will tell you, nobody wants to ration their insulin. Okay. Even when we talk about eating disorders and we talk about people omitting insulin, kind of the slang term is diabulimia. But kind of the more accurate is kind of ED-DMT1. So eating disorder, diabetes mellitus type 1, or you could do T2 for type 2 diabetes. Even for people who are omitting that insulin as their kind of eating disorder symptom, again, I wouldn't say that you're struggling with a mental illness, right? I don't think if you weren't struggling with that mental illness, you would think, oh, this is a really great idea for me not to take my insulin that my body needs because I'm going to have some very serious consequences with complications, hospitalizations, premature death. And so I think it's important to say we still have a massive problem in this country and we still have a lot of work to go till there's equality. I really like JAMA. So it's back in 2020, but it talked about the out-of-pocket spending for insulin, diabetes-related supplies, other healthcare services for privately insured US patients. So again, when we're looking at insulin related to diabetes, kind of related supplies, it's almost equal. Like what we're paying for insulin is what all of our medical appointments almost come to, what all of our insulin pump, our testing glucose, our labs, those should not be as close together, especially with adults. And what I'll tell you about the adults number is when I talk about insulin, okay, this is your required med, right? You're not going anywhere with diabetes without insulin. So if that has to be the first thing you pay for and you're unable to afford it and you're rationing it to string it out to last as long as possible, I'm going to go out on a limb to say you will not be buying an insulin pump because with an insulin pump, now you have durable medical equipment. I have to change that insulin pump every 2 to 3 days, right? You have to initially buy the insulin pump. You need a phone to have it work. Sometimes there's a separate device. Then when we talk about a continuous glucose monitor, that is, again, more durable medical equipment. That is something you have to change out every 10 days. So there's all these things where, yes, those advancements are amazing. They're incredible. In my opinion, if I was asked to be the Secretary of Health and Human Services, I would say, let's put money and investments in on this end to get anybody who relies on insulin on an insulin pump and a CGM, because what it does, and studies have shown this, is it lengthens your life, it lessens these, complications of blindness, amputations, heart disease. Um, but again, we haven't done that as a healthcare system. We're going to have people pay, and then, oh yeah, and if you go to the ER or if you have to get your leg amputated, then we'll pay. But we're just going to kind of hope you can hold on until you go to your next insurance provider, right? And to me, that's backwards thinking. We have not done a great job being holistic in our healthcare system. And so a lot of it is backwards, frankly. And I think this conversation around finances has played now a bigger part with more information that we've gotten. So, financial toxicity is when medical expenses begin to negatively affect all areas of a patient's life, impacting both their physical and their mental health. And so, if we're asking a patient, right, how's it going? Are they on insulin? Are they on an insulin pump? I think there's shame that comes in with talking about if you're rationing or if you're not taking all of your insulin. Because in America, we're very much like we pull ourselves up from our bootstraps, right? We're supposed to be very much kind of in control. We're supposed to be in charge. And as a person with diabetes, I've been told since the beginning, right? There's good blood sugars, there's bad blood sugars, there's uh, good food, there's bad food. When I was diagnosed in the 90s, we even had free food, which was things that had zero carbs in it. Um, so, we have kind of these different parts, and I think it's just important that we realize how much that financial toll is taking on people, and also how sensitive we need to be by talking about it, right? I would always recommend having at least sort of an established relationship, because when we talk about money, when we talk about how somebody is doing with diabetes, it's going to be very personal to them. And I would say that most people with diabetes have had at least one adverse sort of negative experience with a healthcare professional or with a family member or a coworker, either kind of blaming them or shaming them. And so oftentimes then it makes them hold back and not be fully truthful. Now, we know the high cost of medication causes people to either adjust. So this is talking about kind of the rationing. So again, their physician, their endocrinologist, their diabetes nurse educator may say, okay, you need to take this much insulin, but they can't afford it, right? So now they're kind of taking matters into their own hand, which becomes a game of Russian roulette. We've seen this kind of this real financial strain with people with diabetes that are associated with a high A1C level. They have more symptoms um, and declines in functioning. And so again, if you're not taking the medication, which is your life support, the way that a medical professional is prescribing, your body is going to start breaking down. And that hemoglobin A1C has kind of always been like the blood test to see how you're doing with your diabetes. It's kind of like a snapshot of the last 3 months. And so we know if that's higher, again, what they're talking about in this research is it directly relates to that financial toxicity. And so instead of just seeing a high A1C, and again, I know nobody would do this, right? But would say to a patient, you're doing horrible. Like that's a bad A1C. That's a bad, and again, because it's so personal, because the person with diabetes is having to manage it themselves, they're making 98% of the day-to-day management decisions on how to keep themselves alive. We take it very personal. We do. It's So it can be very hard. And so then I know a lot of people with diabetes who just don't go back to see a healthcare professional because they don't want to feel bad. And again, think if you can't afford something, there's a lot of shame around that in our culture. Um, Now we know that over time, patients with cardiovascular disease, we know you can have a higher incident with diabetes who use less of their medication than prescribed due to cost concerns are more likely to be hospitalized. So, again, I know this is not a legislative and policy discussion, but when we're talking about diabetes in America, we are so flipped upside down in how we treat it and where we put the dollars. So we're paying 1 in 4 healthcare dollars primarily because we have such a high incidence of complications, early death. Um, but we're not willing to invest that money on the front end and say, let's try to have more control over the list price of insulin, or let's work within our healthcare system of how can we drop those high deductibles so that it's not an access issue, it's not an affordability issue, that every person in America who needs insulin as their life support can have access to affordable diabetes medication and equipment. So diabetes complications, right? Diabetes leads. Again, we're at the top. This is not where we want to be number one at. We lead with heart disease, stroke, blindness, kidney failure, lower limb amputations, among other conditions. 94% of people with diabetes, again, this was a CDC National Diabetes Statistic Report from 2022. 94% of people with diabetes had at least one diabetes complication during their life. 2 out of 3 die of heart disease and stroke. Your risk for cardiovascular disease mortality is 2 to 4 times higher just by having diabetes. Uh, we are the 7th leading cause of death, though that number has long been underreported. Because most times, if somebody passes away, let's say of heart disease or a stroke, that is what is listed. It is often not listed that diabetes was the cause, right? So we've had to work as diabetes advocates to how can we get better, accurate numbers so we don't continue to get so underfunded because our numbers are not showing accurately. So people with diabetes are 2 to 3 more times likely to have depression than people without diabetes. Only 25 to 50% of people with diabetes who have depression actually get diagnosed and are treated. People with diabetes are 20% more likely than those without diabetes to have anxiety. And I'll stop after those first two. This could be a whole presentation of why are we at such a higher risk and why is it such a high number for not getting the diagnosis and the treatment of depression or anxiety. So one, somebody with, I'll just say type 1 diabetes, we have to make an additional, I've seen a statistic, we have to make an additional 185 decisions a day. So every moment of my day, I'm having to think, what's my blood sugar? Do I have enough insulin? Do I, what am I eating next? How much insulin do I give for said eggs and bread for breakfast or for coffee or, right? So there's all these different decisions. So yeah, that would cause a lot of people anxiety. And if you think about insulin, a simple little drop of insulin, literally like a minuscule, can change if you live or die. And we're the ones, we are not, now again, some people with diabetes are healthcare professionals. And actually, Center for Change has an incredible diabetes team made up of a lot of people with type 1 diabetes, which I love. But I never wanted to be a doctor. I never wanted to be a nurse. I was not good in any of those subjects. But now I'm the one having to make those decisions. And there's serious decisions and there's serious complications, serious ramifications. So yes, I can see on just a very simple first look, first glance, you can see why somebody would have increased anxiety with diabetes. Also, the thoughts about money, how they're going to pay, what kind of insurance are they going to have? I ended up getting married early, going to a courthouse with my now husband when the pandemic hit so that I could get on his health insurance. Like, that's crazy to me in America in 2020. People are deciding to marry somebody sooner or later based on if they can afford their diabetes medications. Women with diabetes are 2.5 times more likely to be diagnosed with an eating disorder. I myself struggled with an eating disorder for years. Now, not everybody with diabetes and eating disorder omits insulin, but we know that there is this higher risk. We also think because there is such an emphasis on food, weight, numbers, right? This kind of obsession right out of the gate of getting diagnosed with diabetes, that can cause an increase in those numbers. So again, I was diagnosed with an eating disorder. My younger brother grew up in the same house. He does not have an eating disorder. But what I say sometimes he's had disordered eating? Yes. Unfortunately, diabetes really can set you up, I think, for failure in a lot of ways. And that's why the impact of healthcare professionals is crucial. And the language you use and the approach you use is crucial. We also know there's a heightened suicide risk. So again, there is a lot on the plate of somebody with diabetes. And then again, you also have life. So I'm just listing the 185 extra things that I have to decide a day to keep myself alive. But I also have kids. I also have a husband. I also have to work. So I also have family. So there's all other things. So we know with comorbidities, just under 98% of adults with diabetes have at least one, and 88% have two comorbid conditions. I just saw my spelling error, sorry. And up to 40% have at least three. So again, you're not just thinking then about diabetes. Now you're thinking about diabetes and amputation. You're thinking about diabetes and vision loss. You're thinking about diabetes and depression, diabetes and an eating disorder. So the list can really go on. This is a picture of my brother and I when I was diagnosed in 99. The physician who diagnosed me said, Quinn, if you can just hold on for 5 years, you will be cured of diabetes. And we've heard a lot of talk over the years about that. Here's what the sad thing is. When I was out in Washington, D.C., this is probably in the early 2000s, advocating for a cure for diabetes. That's all we talked to the federal government about. Now, fast forward the 25 years, now what we talk to the federal government about and the state government and anybody who will listen is people are dying because they can't afford insulin. We've had to completely put a cure on the full back burner. I haven't talked about a cure for diabetes for years, probably since this presentation, because again, the focus has been how can we keep 30 million Americans, specifically the 7.5 million who rely on insulin, alive for another day. And we have a lot of people who are passing away from the disease. Now, for best practices, again, I have a master's in communications. I did my own research on communication messages and how that impacts somebody living with diabetes. I always say, first and foremost, we all can't be an expert on every single chronic illness. So even though you're the healthcare professional and you probably have a lot more education maybe on the topic, the person who's living with it has been living with it 24/7. They've been on their own for the most part, having to make these decisions. So I always think the best approach when you have these appointments, these sessions, is think about asking open-ended questions opposed to statements. So when you see that high, maybe A1C, you don't kind of go, oh, like you must really be struggling, right? But instead asking, um, tell me a little bit about, when you were diagnosed. What do you think is the most difficult part about managing diabetes in 2024? And again, I think when you foster that relationship, there's more trust to open up. Regularly screen for the side effects of financial costs. Again, I think we never used to talk about that in medical appointments, but now that is probably one of the biggest issues for people with diabetes and having great care. I think also looking for those signs of depression and anxiety. We also see a reason why a lot of people don't get diagnosed with those because they're already burdened with the number of medical appointments and financial costs just to stay alive with diabetes. So now to think about having to go to another specialist, right, to be screened for depression or anxiety, to go to a therapist, well, that's going to cost me more money. Even with the eye doctor, most medical insurance plans in this country will pay for one diabetic eye exam a year to an ophthalmologist. Most people with diabetes will not go in until there's something wrong, unless they're having pain or eyesight issues. And again, they are just overburdened with the financial cost, with depression, with anxiety, and just trying to survive with diabetes. Third, treat holistically. Again, we can't just say, okay, take your insulin, eat this many carbs a day, and get 30 minutes of outdoor exercise or whatever, right? We have to look at all these components. I had a doctor that once said, an endocrinologist, he said, Quinn, if I don't understand what's going on up here, I'll never understand why your blood sugars are like this. And then I think also throwing out those labels and those assumptions, because again, there's a lot of misinformation. And by blaming and shaming anybody with a chronic illness, I don't think that's going to get us to our common goal of having somebody live their best life and a healthy life and a life where they can really thrive. Um, and, uh, so I think looking at those, I know I talked briefly earlier, and I know we are coming to the end of time. I'm always shocked this goes so quick. But like when I was talking about like specific areas of the country, like those non-metropolitan areas, I can send this to people afterwards, but there's 813 US counties that are designated in the United States as insulin deserts, which those are counties in the US with both high rates of uninsured people and of um, high rates of diabetes. Oh gosh, I can never get this. I know this isn't a great picture, but what you can see is it's a large part of the South. It's a large part in very rural areas where those insulin deserts are. So we also know food deserts, right, are also hit. It's a very similar kind of map. And we also know if people, maybe stop their education in high school or right after high school, they may not have the information to know or the income to be able to go in regularly to see a doctor to get checked. And so that's where our struggles start and continue. And that's why we want to treat every person as a human being first and foremost, never as, oh, you are this because your blood sugar is this. Because again, there is a huge story after that. And very quickly, here's my beautiful baby, Bo. He was born on New Year's Eve. You'll see me. Here's my insulin pump and my CGM. And what I will say in closing is, yes, I had a beautiful baby. And a lot of times during that pregnancy and then after, people would say, "Oh, you did such a great job. Oh my gosh, you did so amazing. Like you have diabetes and you're this beautiful baby and no complications." And what I would always want to say, which sometimes I would say is, yes, I did, but it was because I had privilege and access to diabetes technology, to insulin, to medical appointments. I was able to go to my twice a week appointments at the end of the pregnancy. I was tested, I was watched, not everybody is afforded that in this country. And so we need to get to a part where there is more equality and accessibility for, again, technology and medications that have been around for 100 years. So I want to end on the work that you all do every day is critical. It's important. And we still have work to do. So to 2025, let's continue that work. And I'm happy to take a couple questions.
Thank you, Quinn. As you can imagine, we have a significant number of questions, which is awesome. So we're going to get to a few. I'll tell folks right now, I know there are a lot of clinicians on and that may need to hop off at the top of the hour. So let me say this quickly, which is, if you have a burning question that we can't get to, you are more than welcome to shoot an email to me at cfcwebinar@gmail.com. It's the email that you see in all of the confirmation emails that you receive from our webinar site. So CFC, as in Center for Change, cfcwebinar@gmail.com. just send me an email and I'll forward it to Quinn. And and she can answer it from there. So, because we definitely won't get to all of them today. And then lastly, before you all go, and we do some questions, two things. Number one, when I end this webinar, or if you leave, in the screen that you see now, where you see my face and Quinn's face, there will be an evaluation, a webinar evaluation that will pop up. That's asking questions about how we did on the webinar. If you'd be so kind as to take a minute to complete that, we would appreciate it. It's completely anonymous, so feel free to be candid in your feedback. We tabulate those results and send those to the CE approval bodies. That's a requirement for us. So if you can do that, that'd be great. And then also when the webinar ends or you hop off, you'll see in a separate browser tab. So on your phone, dig deep, because it'll be way back there in your tabs, in your browser tabs. You will see a separate new browser tab that pops up with the link to take the online test. If you'd like to receive continuing education credit, you need to take the test online. And once you pass the test site will, you'll see a button that says click here or click here for your certificate. So you'll download your certificate from the test site. We don't send it to you from Center for Change. It comes automatically from Classmarker, which is the name of the test site. All right, Quinn, here we go. Let me get to the top. Okay. This was from an anonymous attendee, said, I often hear the term, my diabetes is in remission. Is this an accurate term to use for those who no longer need medication and A1C is within normal range?
Yeah, so you'll hear that again with people with type 2 diabetes. They'll say it's in remission. I'm not a medical professional, so don't take your answer from me. I just obviously am openly vocal on my opinions about diabetes. I think using the word remission gives the perception that you don't have to think about it anymore, right? That it's like dormant, that it's gone away, similar to a cure. I think it's a softer word for saying I cured diabetes to say it's in remission. I guess you're in remission from treating it with insulin. But again, I think it's important that we tell people that there is no cure for diabetes. That yes, of course, if you're with type 2 and we can eliminate or limit the amount of insulin or oral medications you're on, yes, of course, that's the goal, right? But you still have type 2 diabetes and you still want to be hyper aware, even if some of those treatment measures have gone away.
Thank you. You were holding up the bottle of insulin, and there's a question about how long does that bottle last? Does that last you for a month? Is that every month? Is that every week? Can you speak to that?
Great question. And I should have thought about that. I usually do, but I didn't. So for me personally, again, everybody with diabetes is different with the way their body functions, their weight, their age, hormones, fill in the blank. I go through about 2 of these a month. If you're on an insulin pump, you only use short acting insulin. So I go through about 2 of these. But again, I've been on trips with people to Canada where we're going to get affordable insulin. And I know one young gentleman who's my age, he has 7 vials a month that he uses. So again, different people is different uses of insulin. But I would say for the majority, you're probably at least about 2 vials a month
Thank
with
you.
type 1
So
diabetes.
then the cost that you talked about doubles and triples, and it's
It
extremely
doubles. And
Right.
again, that's just one of the expenses, right?
Right.
Like, and we know in the US, it only costs a pharmaceutical company about between $4 to $6 landed to manufacture this, to produce this. It is not expensive to make, though it's one of the world's most expensive liquids.
And along those same lines, one of the comments that we had, this is from Elga, I think is how you say your name. I apologize if I got it wrong. They said this is not a question, but a comment. It is not just rationing insulin because of the high cost. It's rationing insulin pump supply. Instead of changing every 3 days as recommended, patient changes the cartridge every 4 to 6 days, resulting in increased risk of infection, et cetera, et cetera, et cetera. So it's not just the rationing the insulin itself, it's everything that goes along with that.
1,000%. And thank you for adding that because that is totally true. I mean, there's diabetes Facebook pages that I'm on that are all about like cracking how to extend the life of the insulin pump kind of sites, as well as the continuous glucose monitor. There's sort of like a 10-day limit on that, and then like a 72-hour limit on my insulin pump. And so there's like hackers and how you figure out how to extend it. And you are correct. The longer you have that on you, increased infection. And then if you have a higher A1C, that infection is not just kind of, a base level infection, it is a lot more serious. And
Right.
especially if you have higher blood sugars, to try to heal that infection can become very complicated. So excellent point, and thanks for bringing that up, because again, it's not just one thing. It's
Right. It's a whole domino effect. And
totally.
there are more questions around that, and so I'll just put it kind of generally, because there were Ken asked and Jeannie asked, Ken said, so what can those of us who are rationing do about it? And Jeannie said, is there an organization or entity that advocates for impoverished individuals with diabetes diagnosis? And there were comment and question after question about how can we help? How can we advocate? Is there a place where we can volunteer? That kind of thing.
Yeah, so I'll say I have volunteered with probably every diabetes organization over the last 30 years, and a lot of them are phenomenal. But with the issue around insulin rationing, I now exclusively volunteer for a nonprofit. It's called T1 International. They have a chapter, or they are out of the UK, but they're also in the US. I'm actually the lead of the Minnesota state chapter. It's all volunteer led, but they take $0 from pharmaceutical companies, health insurance companies, PBM. So there's no conflict of interest. And we advocate for, again, legislation on a state and a federal level of how can we actually fix this issue. And so that is where I go for my information. That's where I go to see, because I think it's the most unfiltered. Also, if you want to connect with your state chapter, there's usually kind of a head in each state. They can connect you. If you live in the state of Minnesota, please email me now. I think, did you say it was Ken or somebody maybe asked if you're currently rationing? If you are in the state of Minnesota, email me, call me. I can get you insulin today. Now, I can't say that about every state in this country, but we have passionate advocates. And so, Ken, if you email me and say, this is where I'm located, I bet within a couple days, I could find you several vials of insulin. We have sort of this inner working. And yes, are we not supposed to kind of give other people insulin? Yes. But again, that's where we're at in America, is where I meet up in parking lots with strangers across the metro to give them vials of insulin in garbage bags.
That's so
Because
sad. It's so sad.
so again, each state, and again in Minnesota, we work to get an emergency insulin bill passed, but we are one of the only states that currently have that. And the moment we got it passed, pharma has put millions into trying to tie it up in the courts to say it was an illegal move by the state.
Thank you. Okay, we'll do two more questions. This one, I really liked it. How do families navigate independence and safety in type 1 children when they emerge into adulthood?
Oh my gosh, bless my mother and my father with two young type 1s, and not having insulin pumps back then, or not having CGMs back then. What I'll say is my mother said something really interesting when I was diagnosed. She said, I was sad because Quinn was diagnosed with diabetes, and I was sad because we knew what diabetes already was, right? And so this inherent need as a parent, as a guardian, to make sure your kid is just alive. I have a 15-year-old stepdaughter. It's like the roller coaster of a teenage girl is wild. Then you put on type 1 diabetes, right? And they don't want to listen to their parents. They want to like go out with friends. I know my brother, for instance, who didn't wear an insulin pump for all these years. He just got married like 2 weeks ago, and he just put on his first insulin pump. And if you really get down to it and ask him, it's because he did not want other kids treating him differently if they saw an insulin pump on him. Right. And so I think it's about making sure your child feels supported and that you encourage positive friendships in their lives. I would talk to Will because him and I both were dumped by people because they were like, oh, diabetes is too much, or oh, diabetes is contagious, or oh, I had one guy in my 20s say, well, if I had a kid with you, our kid would have diabetes. And it's like, well, that's not fully accurate. But to have parents or guardians to be like, those aren't your people, move on, right? And to also see, is there a therapist who would also be a good fit, even if they're not showing signs of clinical depression or anxiety or an eating disorder? My parents had me seeing a therapist the moment I was diagnosed. And I will say, I think it helped me tremendously, just having that component where I felt I could trust somebody. And then lastly, I'll say, my mother said to both my brother and I, if you guys want to be independent kids, you need to show your father and I that you are listening in your medical appointments, that you understand about testing your blood sugar. Now it's on a CGM for most people, that you know how to dose your insulin, that you know how to carb count. And my mom said, look, if you can show us that you can do that, you don't have to be perfect. But she said, then I'm not going to follow you around. But if you can't master those things, she said, I can't let you go to a sleepover. I can't let you go to prom. I can't let you study abroad in Africa for 3.5 weeks. Right. And it was like that thought for my brother and I of like our parents following us around, like was just like, oh my gosh, like we will listen to what that doctor tells us. And so again, but then also if nobody with diabetes has just perfect numbers, no
Right.
matter what technology you have, no matter what insulin you have, you do not, your line of blood sugars, I'm sorry, does not look like this. Now, some people show that on social media. God help you. I don't know, like you're praying a lot. Not for me. So my whole point is then if your child does have a really bad low blood sugar, or you do see after they come home from a hockey tournament that they struggled with high blood sugars, ask questions instead of make those statements. Ask them questions so they feel like you're trying to understand them instead of making an initial judgment. Though I know from the parents' end, what you're thinking and saying is, oh my God, I just want you to stay alive.
Yeah.
Like that's what you're thinking in your mind as the parent. But the way that the kid is translating it is, oh my gosh, you want to bubble wrap me for the rest of my life. And if my number is anywhere outside the number of 100, I'm going to be punished. And we don't want that. So I think it is an impossible balance, though I think we can all try on all ends.
But a worthy goal. Yeah.
It's a worthy goal. And I would also say, let your children have a part in their diabetes management, no matter what their age is. So yeah, if they're 5 years old, yeah, maybe you don't want them drawing up the insulin and giving it to themselves, but you could have them pick the color of insulin pump they use. You could have them take initiative with fill in the blank.
Yeah.
So get them involved at an early stage in age appropriate ways.
Thank you. All right, last question. Quinn, this is from Michael. Quinn, how do you suggest having a conversation with someone with diabetes that doesn't accept their condition or actively engage in their self-care? This question popped out to me. We have as Quinn mentioned, we have a EDDMT1, type 1 diabetes and an eating disorder program at Center for Change. And one of the groups that we offer is a chronic illness group for that very reason, that right now there is not a cure for type 1 diabetes. And that's something that has to be discussed and worked through and processed and grieved about. So Michael's question about how do you start a conversation with somebody to help them accept what's going on?
Yeah, I mean, that's the question, right? I'll have people, I graduated high school with a guy who ended up being a podiatrist, and I remember him at my high school reunion saying, oh, well, you're such a good diabetic, Quinn, but the patients I see, right, like they don't care, they don't. And what I would say is, I think every person with diabetes wants to be alive. The majority of people with diabetes had zero choice in getting this disease that is very complicated. And so how that impacts your mind, right? And just I'll say, I think there's whole books on it. I think maybe Tamara, we've even done a presentation on this about diabetes burnout. You are burnt out. We don't get a day off from this disease. I have to do it 24/7. Everything is more complicated. If I get the flu, it's more complicated. If I have a surgery, it's more complicated. If I have a baby, it's more complicated. Okay. And just to be at a base level, you're exhausted. And so I will say, I think it is natural for somebody with diabetes to be like, look, I'm sick of this. This sucks. and I just want a couple days off or a couple weeks off. Now, again, I think in the past, we would look at that and say, well, that's a non-compliant diabetic. They are non-compliant. And what I would say is, I don't believe in non-compliance of a person with diabetes. I believe that they were handed a really tough hand of cards. And what can we do as a healthcare professional, caregiver, friend, peer to support them, to say, look, we see you, right? Like people who have told me this for years, they'll say, well, I hate needles. I would never be able to. And it's like, okay, well, then you're going to die. So you don't have much of a choice. I don't like needles either. Like, so it's like putting yourself in that mindset of like, there's no end. There's no, right? And I was told at an impressionable age from my doctor, Quinn, there will be a cure in 5 years. By the time you go to college, you won't have to think about this. And then guess what? The 5 years came and it went. And now I'm 20 years past that. And you have individuals who are pissed off and resentful because they were promised things, they were encouraged things, they made it, and then they went down the cliff. And so I would say some appointments, maybe you're not talking about like the brass tacks of diabetes and blood sugars and food. Maybe some of those appointments are about what is the hurdle for them? What is that exhaustion? What is that exhaustion point? And maybe to boil it down really easily, what is the next best decision you can do? Because what we know is the longer somebody goes, obviously with higher blood sugars, that's where we see the increased risk for those complications. So whatever an individual can do, even in that moment, the next day, the next hour, to make the next best decision, everything in the past is in the past. So it's about helping with a mindset and a different way of thinking. The truth is, I got diabetes. It wasn't my fault. It sucks. I don't want to have it, but I get to make the choice on how I want to react. And I think that's where the power can lie. And that's where the power can lie for healthcare professionals who are very influential to a patient who's really struggling and who are really tired and they really need a helping hand, but they also, this kind of a warm and fuzzy, they just need an open heart. They need an open and caring heart for somebody to see them and say, look, I cannot imagine how tough this is. How can I help you?
No. Thank you, Quinn. What a great presentation. I'm so thrilled to spend time with Quinn and with you all, and grateful that you all we still have a ton of people hanging on and we're way past time. So
Thank you.
oh my gosh, thank you, Quinn. I just want to tell everybody it's been a great year for webinars from Center for Change. We've thoroughly enjoyed them, and we get great feedback from you all, and we're so glad that you participate and enjoy them. Know that they're coming back in 2025. We're going to take the holidays off, and so we'll see you early next year. Keep an eye on your emails for information about our upcoming webinars. And in the meantime, stay well and healthy and enjoy your holidays, and we'll see you soon. Bye, everybody.
Bye. Thank you all so much.